We are starting with the reproductive part now. We have completed our endocrine part, right? So this is my first lecture, and Dr. Muhammad will be taking the same from microbiology part here. Okay. So when I am reading, we'll just look into normal looking some things which you should recall your memory. So you know this is vagina, this is uterus, this is fallopian tube, and this is ovary, right? This is cervix. So uterus has three parts: cervix, body, and body. The what's called fundus. Good. Then we have fallopian tube and fibria here, and ovary. Ovary, as you know, that during childbirth time, they have almost 2 million primordial follicles, means they are about to make into ovum. And at the time of puberty, it only remains 400,000, means remaining were almost degenerated. Okay. So as the ovum comes out, it is taken up into this fibria up till here, where it is fertilized, and then it takes 2 to 3 days or 4 days to come and launch here. Now all thing depends whether it is fertilized or it is not fertilized. It is fertilized, then that the Griffin follicle which ruptures, it will convert into corpus luteum, and you know that the progesterone started secreting it. Before that, it is the estrogen which has been secreted from these venereal cells, right? Up till the 14th day. In 14th day, there is a surge of LH hormone. This is all due to the FSH hormone, right? So let's go back. So then, if there is LH surge, ovum come out here, then there is the sperm from here comes into the fallopian tube. So the fertilization takes place here, and it takes 2 to 3 or 4 days. It travels, and up till that time, the proliferative endometrium changes into the secretory endometrium. Now, the fertilized ovum, when it comes here, it has been received by this endometrium, because a secretion is so sticky that it holds the ovum, the fertilized ovum there, and then remains there for 9 months. Now that which I had shown you, the corpus luteum, it starts secreting progesterone for the next 9 months. Now it is when it has been fertilized. If it is not, then this ovum, the life is 24 to 36 hours. It moves and then it drops here, and then it is excreted out. Okay. Now this is very important part of the cervix, which is endocervix and ectocervix. And these are endocervical gland, and the cervix, the outer cervix, the exocervix, is lined by stratified squamous epithelium, and you have squamocolumnar junction here. Now what's the difference between squamocolumnar junction and the transformation zone? Anybody knows it? Yes. Line. Say it again. Okay, let me clear it. She's going towards it, it's okay. But what happens in menarche? You know what is menarche?
Yes.
Menarche is the first menstrual cycle start. What happens that in menarche, the endocervical gland comes out here like this. This is called cervical erosion or ectropion. the endocervical glands comes out, and it comes out like this. This is squamous epithelium true. This is erosion, or probably you can say these are the endocervical gland which is now coming out. Now you had to have squamous epithelium because squamous epithelium is a very strong epithelium and you need to have that. So what happened that this columnar epithelium get metaplastic change and convert into squamous epithelium. That's why we call this thing as a transformation zone. This squamous epithelium which is looking like squamous actually is not squamous. Actually it is columnar epithelium which has been changed into squamous epithelium, means squamous metaplasia. Now what's the difference between these two? Why we are always looking for this transformation zone? Why? Because this squamous epithelium, which is original squamous epithelium, is so hard that HPV cannot get through inside, right? It is so tightly bound. But this metaplastic squamous epithelium is not that much strong. So whatever HPV comes in, it directly damages the transformation zone and enter into the cervix. Clear? I asked this question in 4th year. When you come there, and I'll ask the same question, and majority of you doesn't remember. This is very important, remember. So, while as a pathologist we ask for pap smear, you know what is pap smear? We just take these cells from the cervix and then we spread on the slide, we stain it, we see under microscope. And if we don't see metaplastic epithelium, then we call this thing as inadequate pap smear. If we see metaplastic epithelium, then we call it as adequate one. Why? Because if the gynecologist has not taken the pap smear properly, she has taken only the ectocervicous squamous epithelium, not the metaplastic endocervical cells, it is inadequate, right? I think in your case, your PPL case, which is going on now, we have a pap smear, and I have given one slide of that one, showing the normal and abnormal one, right? Okay. I think it's understood now, completely, yes.
Why do you say cervical aggression? Is it normal?
It is normal. Every girl in menarche, it happens like this. So the endocervical glands comes out, it causes changes, metaplastic change into squamous epithelium, and remains there. That's a transformation zone. So if anybody asks you difference between transformation zone and the squamocolumnar junction, this is the answer, right? Yes.
And it stays like that.
Like this, yes, throughout your life. And that's the reason why HPV virus get its entry from this point. Okay. Now this is ovary, you know, that we have a lot of primordial follicle, which I said more than 2 million when the child is born. At puberty, only 400,000 left. Only one lucky ovum per month get chance to become primary follicle. It will convert into secondary follicle and then the tertiary or Griffin follicle, right? Now, when it becomes, for becoming from primary to secondary, it has a granulosa cell which starts secreting estrogen. So remember, first 14 days you have estrogenic secretion, which is actually building up the endometrial layer. As the surge comes of LH, this is under the influence of FSH from the anterior pituitary. As the surge of LH comes, the ovum comes out, burst comes out, and then it closed, and this whole thing will convert into corpus luteum. And now, as the corpus luteum is formed, instead of estrogen, now progesterone is being formed. And this progesterone is converting that particular proliferative endometrium into a secretory one. So first 2-3 days it is early secretory activity in which you can see subnuclear vacuolation of the glands. I'll show you. Okay, it's clear? So in ovary you have medulla, this is medulla, and this is cortex. It is lined by epithelium, right? So like any other one. But the important thing is, it is not attached to this fallopian tube. So it hangs like this one. This is ovary, and this is fallopian tube, and these are fimbria. They are waiting for the ovum to come out. As it comes out, they grab the ovum, and then it takes in the midline of the fallopian tube where fertilization takes place. This is the histological, this is the diagrammatic one, this is logical one. Pre-body follicle, primary follicle, second follicle. This is secondary follicle, this is Griffin follicle, and as the surge comes, it will burst this ovum out. This is ovum out. Okay. Now this chart will show that the cycle start primordial follicle up till the Griffin follicle, then this anterior pituitary in the initial 14 days, the follicular stimulating hormone, which is green, starts secreting slowly, and the endometrium is getting up like this one. And then what happens that on the 14th day, this blue line, which is surge, LH surge, which comes out, ovulation take place, and then in the initial 14 days, the estrogen, estradiol, is coming up to the top. As the surge comes and ovulation take place, it drops down, and now progesterone will come out. Although we have some of the estrogen also, but it is overcome by progesterone. Now the function of the progesterone is to make this endometrium more comfortable for the ovum to come and lodge in. This is secretory activity. That's why we call it secretory endometrium. So it starts from day 0, means the first day of the menses start here, 4 or 5 day, and then due to the effect of FSH, estrogen comes up till here. So proliferative phase comes up, surge, now progesterone comes up, more secretory activity, these are spiral arterioles which are coming up, and if fertilization does not take place till here, the endometrium shades again. So it is again day 0, 28th day of the menses here, or day 0 of the other cycle. Now, yes?
Would it be considered correct if we say that luteinizing hormone...
Loudly, please.
Would it be considered correct if we say luteinizing hormone is
Luteinizing hormone, yeah.
The production of
Anterior pituitary, yeah.
Stimulates the progesterone secretion.
Progesterone, yeah. Why? Because when the surge comes up here, right, it's, the ovulation take place. Remember, it's very important thing. When ovulation take place, the same follicle which was secreting estrogen here, now it converted to corpus luteum. Instead of estrogen, now it's secreting progesterone. Now this progesterone actually acting on the endometrium and doing the secretory activities. Before it was doing proliferative activity, now it's a secretory activity. And secretion is going on because they made this endometrium so sticky that the fertilized ovum, when it drops down, it has been taken by the endometrium. Clear? Okay, so this is actually the same chart showing different thing. This is a proliferative phase, and then this estrogen comes down, and here you can see mitosis in the glands. This shows that the glands are active. Remember, you must see mitotic figure. This mitotic figure doesn't mean that it's a malignancy. Remember, it is not only malignancy which causes mitosis. Normally, if there is some proliferation going on, you can also have. Now, after the surge, tortuosity of the gland increases, and there is secretory activities go on. Here at the 14th day, when the surge goes out, then there is early secretory activity, and there is basal vacuolation of the endometrium. I'll show you later on. And finally, the secretion goes more and more, and inspissated, in thick type of secretion will go. Stroma become more and more edematous, and pre-decidual you can also see after ovulation 11th day. You can start looking at the neutrophils which are coming up now, and it is just a precautionary measure. When bleeding take place, there is a chance of infection, so body has prepared itself that neutrophil will come there before 1 or 2 days of menses. Clear? Should we move now? Okay. Now these are the different type of endometrium. The first one is a proliferative endometrium, in which you can see a rounded looking gland, and you can see mitosis here. After the surge, 14, 15, 16 day, you can see subnuclear vacuolation. You see the nuclei are pushed up, and just beneath the nuclei you see vacuolation. This is called subnuclear vacuolation. This is called early secretory endometrium. This is the late secretory endometrium, in which the stroma become more and more edematous. You can see spiral arteriole. The endometrial gland become more tortuous, and secretion inside one. This is pre-decidual one, means you can see a lot of spiral arterioles, and decidual reaction means more pinkish like stroma are visualized. This is 1 or 2 days before menses, in which you can see a lot of inflammatory cells, which is neutrophils, and then at the 28th day, breakdown of the endometrial gland take place. This is called menstrual endometrium. Now make it a little more clearer. This 4 picture. The first one is proliferative endometrium. You can see endometrial mitosis. So this is active looking gland. Remember, active gland. Inactive gland, I'll show you in a pattern in which we have inactive gland. This is active gland, and the stroma is so compact. You see, stroma. This is subnuclear vacuolation. The nuclei are pushed up, and subnuclei there is vacuolation taking place, right? This is late secretory endometrium, in which tortuous looking endometrial gland, and it is full of secretion. Clear? And the stroma is becoming more and more decidual reaction. This is called decidual reaction, more and more pinkish in color, right? And just before the menstruation, 1 or 2 days, you can see neutrophils also. And finally, this is a breakdown of endometrial glands, and you see a lot of hemorrhage. So this is called menstrual endometrium. You can see sometimes neutrophils here. This is what it is pointing out. That neutrophil you may see. This is just a defensive mechanism of the body. Clear? Should I move? Any question? Remember, you can stop me anytime in the middle of my lecture if you are not understood clearly. I will repeat it again and again for you. Yes.
So decentralization is on it?
Decentralization.
That's what I'm talking.
Pink, more. The cytoplasm of the stroma, not the glands, the stroma will become more pinkish, thick. Okay? It is more evident here. You see? You see the difference between this stroma and this stroma. This is also secretory stroma, but in the later stage, means at 20th day, after that, you will see residual reaction. 1 or 2 days before, you see inflammatory cells also, and finally, menstruation. We have some condition in this which we will be discussing. Functional histology, which we have already discussed, DUB, dysfunction uterine bleeding, inflammation, adenomyosin, endometriosis, and finally endometrial polyp. We'll start with this chart will show when you will be getting which type of disease. Pre-puberty, or precocious puberty, in which you can have a disease either because of the hypothalamic pituitary or ovarian. Mostly some tumor which can cause precocious puberty of the child. Then in adolescents, the most important challenge is an ovulatory cycle. As after menarche, it takes 3 to 4 or 5 months to adjust the body accordingly. So sometimes the girl will have menses, and then next month no menses, then menses. So it's the starting period in which an ovulatory cycle takes place. It's normal, it's not abnormal. And finally, after 6 to 7 months, it becomes regular. No ovulation takes place. Then probably some disorders, cognitive disorder may cause that one. In reproductive age, complication of pregnancy take place like abortion, trophoblastic disease or ectopic pregnancy, organic lesions like leiomyoma, adenomyosis, polyps, endometrial hyperplasia, carcinoma, dysfunction retroactive bleeding like an ovulatory cycle or ovulatory dysfunction bleeding. This is what we will discuss. Inadequate luteal phase. Corpus luteum is formed, but the progesterone is not developing properly. Then we have perimenopause. Just before menopause, you can have again an ovulatory cycle. After, for example, 12-13 years when menarche takes place, now it is almost 45-46 years. Again, she is feeling an ovulatory cycle. Menses comes, next one no menses, then menses. So this again start in menopausal time, and finally complete stoppage of the menstruation, and then irregular shedding which take place there. Organic causes like carcinoma, hyperplasia, and polyp, and post-menopausal, after menopause. There we have some endometrial atrophy, in which an organic causes we have carcinoma, hyperplasia, and polyp. So we are having these 5 things which we are going to discuss today: ovulatory cycle, inadequate luteal phase, oral contraceptive, menopause, and post.
Doctor,
Yes.
is the unovulatory cycle related to PCOS?
Yes, it is. But PCOS is one of the cause of an ovulatory cycle, and that is something different. We will be discussing inshallah tomorrow, right? It happens that the ovary outside the epithelium become very thick. Even ovulation takes place, but the ova cannot comes out from the follicle. It remains inside, so the follicle does not throw the ovum out. So it remains inside, and the corpus luteum will not take place. Okay, an ovulatory cycle results from prolonged estrogenic stimulation. Why? Because ovulation does not take place, so the conversion into corpus luteum is not taking place. So the same estrogen is being secreted by granulosa cells rather than changing into corpus luteum, which secretes progesterone. Okay. So we don't have progesteronic phase here. Usually it starts during menarche, as I said, or premenopause, when the lady is converting into menopause. Less common causes are thyroid disease, adrenal or pituitary, some tumors like granulosa cell, thicker cell tumor, which can cause this one, or polycystic ovary, as you have mentioned, right? And we have some other metabolic disturbances like obesity, malnutrition, chronic systemic diseases, diabetes is also one of them. Yes.
They happen at menarche or at the perimenopausal
Perimenopause, yes.
Is this considered normal?
Normal. I have seen some of the, because being a doctor, so your patients come to you. She's absolutely normal. She came to me that I'm at the age of, sometimes the perimenopause or menopause start after the age of 50. It depends. It starts from 45 to 50. And she came to me and she said, Dr. Brad, I don't know how my menses doesn't come next month, and am I pregnant? I said, just wait. And you are now, did you have menses last? Yes, last month I had. And this is called perimenopausal phase, in which you can have menses, then next month you don't have menses, again you will be having menses, and finally a time comes that completely blockage of the menses. Right? It is not possible actually. Until God Almighty, Prophet Abraham, her wife was menopause, and then by the grace of God, she develops pregnancy. Right? She said, how can I? Yes. because that ovulation is an ovulation, not a complete ovulation. Means the ova does not come out, it remains inside. So the corpus luteum does not develop. It is very important that the estrogen will be taken up by progesterone. You need to develop a good atmosphere inside the uterus to hold that ovum, right? Fertilized ovum. If ovulation has taken place and fertilization has taken place, I have seen that at that age even the lady become pregnant in the last 40 years of age. But that pregnancy is a very, very dangerous pregnancy. You have to be very careful, very careful, right? Okay, so so in this what happened, there is failure of ovulation take place. So more and more estrogen, no progesterone, and it remains like this, and you can see a cystically dilatation of the endometrial gland, and then it remains for 28 days until menses take place. A menstrual cycle comes up, and again the same cycle starts, and this thing ends. Finish. You don't need any treatment. The only thing is the female after 12 days of the ovulation, which does not take place, ovum remain inside, no progesterone, so no secretory activity, she will get a spotting bleeding like this, right? So this is what she will say, that we have abnormal bleeding coming up. And it will go automatically when the start of new menstrual cycle starts. It does not need any treatment. And then next month it becomes okay. So this is unscheduled breakdown of the stroma. So this is called anovulatory menstruation with no evidence of endometrial secretory activity. At this time, when a gynecologist do the DNC and send this DNC to pathologist, what we will see? We will see only proliferative endometrium or inactive gland. Yes.
Doctor, since there is an ovulatory cycle, which means that no ovulation is going to take place, shouldn't that increase for endometrial cancer because estrogens?
Endometrial cancer?
Or like a cancer to happen because of estrogen?
No. It does not have any relation with the cancer. This is all normal physiology, right? We are human being, and in human being, these type of cyclic changes do take place, right? Does not relate to the cancer, remember. Yes, if hyperplasia of the endometrial gland take place, then cancer can take place, right? Not like this. Okay, then coming to inadequate luteal phase, as we were discussing. In inadequate, what happened? Corpus luteum is formed. Ovulation has taken place. Ova is out. Ova, where? It is in the fallopian tube. Now the corpus luteum is been formed, progesterone is been made, but the amount of progesterone you need is not adequate. It is not adequate to thicken up the endometrial glands, right? I think I have shown you different periods, that at 12th day, then we have 14-15 day, it is early secretory, then late secretory. So these whole changes will not take place because of the low progesterone. Progesterone was not that much high to cause all of these changes. Infertility will be there, even if the fertilization take place. When the ovum comes out, it is not being held by the uterus because the uterus does not has developed that much. So there is a chance that the same fertilized ovum will go out, right? Okay. So there will be increased bleeding and amenorrhea sometimes. So the endometrial biopsy of an esteemed post-ovulatory change of secretory endometrium will not show. For example, we have a specific, as a pathologist, we have to be very careful. The gynecologist will take DNC she also give us the time. Doctor, this is the 14th day, this is the 16th day, this is the 20th day, this is the 8th day, right? If it is 8th day, what will you see? Proliferative endometrium, active looking endometrial gland. At 15th day, what you will see? Secretory, early secretory, subnuclear vacuolation. At 20th day, what you will see? Tortuous looking endometrial gland, secretory endometrium, spiral arterioles in the endometrium. Yes.
In this case, you could see increased bleeding, but if progesterone isn't there to develop the uterus, how do we?
Exactly. For example, the gynecologist sent that biopsy to me, and she said that it is 23rd day. Right? When I see, it will not look like 23rd day. It will look like either 15 days, 16 days, because the endometrial gland is not that much developed. As a tortuous looking gland, extra secretory activity, a spiral arteriole, no.
So how do we see increased bleeding? Where does the bleeding come from? Would it be the same size?
So, because it is not that much developed, what is the role of progesterone? To hold the endometrial glands inside. So, some of the glands are whole, some are missed because of the inadequate progesterone. So, when they go out, you can have a spotting. Right? Clear? Should we move? It is very important as a pathologist that you should remember each and every day what is going on. For example, if I am talking about 26th day of menstruation, what will you see? And residual reaction, and some more cells are coming, and those are neutrophils, inflammatory cells. Then you will be able to understand, yeah, it's almost 1 or 2 days before the menstruation. So this is how it is counted. Very important. Pathology is really a very interesting subject.
What are the causes of the inadequate menstrual period? Is it constant? What are the causes, and is it constant? Or is the
Which one?
Inadequate.
Yeah, it is because sometimes it happens, especially those women who are not that much healthy, right? So nutrition is very good. In our village areas, unfortunately, the things are more given to the male, and female are deprived of that. If a lady, and this thing is done by ladies, not by males. She will give egg to your son. She will not give egg. She will give a tea and bread. Just take it for the girl. For egg, not 1, 2 eggs. Because he's my son. It should not be done like this. Male and female are equal. Everybody had to treat both of them together. If you have adequate, good nutrition to male and female are the important thing, because they are giving us a generation, right? So we had, and being a Muslim, we have been taught that please take care of your girl. If somebody has 2 girls, means your door of Jannah is open for you. Alhamdulillah, I have 2 daughters and 2 sons. So Alhamdulillah, I think maybe inshallah. And I have, Alhamdulillah, 8 grandchildren. Alhamdulillah. Oral contraceptive. Now, what oral contraceptives are? We give a combination of estrogen and progesterone. We make the ground in such a way that neither it is proliferative nor it is secretory. So if you take endometrium, whatever time, you will have the same response, right? So you can have both the gland and stroma, and that you can see in decidual type of pregnancy all the time. Even in the 8th day, you will see the same. 10th day, 12th day. So until you stop taking the medicine, discontinue, even after discontinuation, it will take 2 to 3 weeks, 2 to 3 months, that the menstruation will start normal, and then the female is ready to conceive. Okay? Okay. Then coming to the menopause and postmenopausal changes, and ovulating cycle is the important thing, which I already mentioned. Or there is ovarian failure and atrophy. Ovary secretes estrogen and progesterone, which is not secreting properly. So what will happen? There will be dilatation of the gland, endometrial gland, which you see usually in hyperplasia, simple hyperplasia. So it is followed by complete ovarian atrophy. Now the perimenopausal stage has gone into menopause. Ovary become atrophy, no more estrogen, progesterone coming out, no more things are. So the gland will look like a simple hyperplasia, which you had to be careful. That's why I'm saying the pathologist will be very, very important person to look after the changes which a female had. Okay? Clear? Anybody want to be pathologist? MashaAllah. Only one. Radiologist? Nobody? When my son, I asked him to be pathologist, he said, Baba, we are pathologists, let me radiologist. So he opted a different track. So he is a radiologist. Okay, so endometritis means infection, itis as we say, endometritis. We have two types, acute and chronic, like other one. Acute usually is because of the retained product of conception. Means either abortion or a normal delivery. During this process, the gynecologist has not cleared the whole product of conception out of the body, right? So what happens? Infection will take place. And mostly group A beta hemolytic or staphylococcus are the organism, but other bacteria can also take place. Usually interstitium takes more importantly. You can see inflammatory cells there. Removal of the retained product and give good antibiotic can resolve this process. The other is chronic endometritis. Again, usually it happens with the chronic pelvic inflammatory disease, as your case of the PBL, right? Also, you can have chronic endometritis in retained product of conception, or if the woman is using intrauterine contraceptive device to prolong the, if she doesn't want to be pregnant, or tuberculosis. This is a nasty thing which we have in our part of the world, very much common, very common. And she had tuberculosis salpingitis. If there is salpingitis, the fallopian tube becomes very narrow and it does not allow ovum to pass through and cause infertility. Chlamydia is a very, very nasty organism because it is intracellular and it is very difficult to diagnose. So you can even have acute inflammation, which is polymorphonuclear, or chronic inflammation like lymphocyte and plasma cell. I remember when I was doing my residency, my professor used to ask me, look for a plasma cell. And I usually take half an hour, 1 hour for one endometrial biopsy to look for the plasma cell. And then, as I see plasma cell, I had to mark that thing and show him that yes, this is plasma cell. So plasma cell is very, very important to call that one as a chronic endometritis. Endometriosis and adenomyosis, you know what's the difference? Endometriosis is endometrium outside the uterus. Adenomyosis, endometrium in the myometrium. So it just goes inside the myometrium. Okay. So endometriosis outside the uterus, anywhere. It usually occurs in 3rd and 4th decade, in which you can see both endometrial gland and stroma. If you have both, you are lucky. Otherwise, sometimes you see only gland and hemosiderin. Sometimes you see only stroma and hemosiderin, right? It usually is important, but sometimes it becomes very challenging when there is fibrosis taking place. Now, descending orders, ovaries, uterine ligament, recto-vaginal septum, cul-de-sac, which is part of Douglas, pelvic peritoneum, large and small bowel, appendix, mucosa of the cervix, vagina, fallopian tube, and laparotomy scars. So these are the places where endometriosis can take place. There are 4 theories: metastatic theory, metaplastic theory, regurgitation, and extrauterine stem or progenitor cell theory. Regarding the metastatic theory, they think that because of the blood, hematogenous or lymphatics, this endometrium gland can travel from one side to other, anywhere in the body. There is a case report that a female had a endometriosis in the nose. So whenever she had a menstruation, the bleeding also starts from the nose. And then when she was operated, everything was okay. And when they did the biopsy of that, it was endometrial gland. Okay. So they can also be seen in surgical procedures area. And the metaplastic means changing of the as other metaplasia. So coelomic epithelium can do or change metaplastic change in anywhere in the body and cause endometritis. Okay. Then we have regurgitation theory. You know, during this cyclic change, sometimes what happens due to the spasm of the uterus, the retrograde action take place, and the endometrium from the fallopian tube enter into the peritoneal cavity. And then extrauterine stem or progenitor cell. So you know that this is a recent theory which was not there before. That this stem cell can go anywhere, can start taking from the bone, move anywhere, and they differentiate into endometrial tissue. Okay, clear? Any question? No, good. Coming to the morphology, you know that you had to have endometrial gland, endometrial stroma, or hemocyte. Three things. It causes problem when you have secondary fibrosis at that area, right? So you feel little difficult with that. So if you have endometrial gland in the stroma, very clear, and plus hemocyte. So sometimes what happens in the fallopian tube, because fallopian tube may have endometriosis, some endosalpingiosis, some fallopian tube gland, you know, maybe it is misdiagnosed as endometriosis because basically they are the endosalpingiosis or the gland of the fallopian tube. Okay. Now features, they have severe dyspareunia, or pelvic pain due to intrapelvic bleeding or intrauterine adhesion. If there is a pain and defecation, if the endometriosis in the rectal wall, dysuria means pain in micturition when you have endometriosis in bladder wall. Intestinal disturbances may appear in small intestine, and infertility occurs in 30 to 40%. In addition, which is uncommon, when a malignancy can take place in the site of endometriosis, which is at risk epithelium. Yes, these are the pictures. This is the gross picture of the ovary, and this is what you call hemorrhage, hemocyte. So this is called chocolate cyst. We call it chocolate cyst because it has converted, red thing is converted to brown, right? And this is the section of this one. You can see these are hemocyte-related macrophages, the lining of endometrial cells, and you can also see some stroma around here, right? This is large intestine, and here endometriosis has taken place. This is also a high power view. This is the large intestinal gland, and these are endometrial gland with the stroma, right? Is it clear that if you see this thing, it's a piece of a cake that you can diagnose easily, right? Okay, adenomyosis, as I said, when the endometrium come deep into the uterine wall, usually we say that about 2 to 3 centimeter it has to be going down, right? So it is between the smooth muscles of the myometrium. These patients may have menorrhagia, means irregular heavy menses, polyp dyspareunia, pelvic pain, particularly during menstrual period. Clear? Okay, this is adenomyosis. It's a uterus. What is this? Anybody? This is leiomyoma, or fibroid uterus. It's a most common type of lesion which you see in female leiomyoma. When this adenomyosis happens here, particularly this one, this is adenomyosis. We call it as adenomyoma. Adenomyosis in the leiomyoma, right? So it looks like this. Good. Then endometrial polyp. Usually, if we think of a polyp, we think of a pedunculated thing which is coming out, right? But it can be either it's projected out. Usually, it is exophytic in shape. Sometimes you see sessile also. Sessile means some raised area, about 0.5 to 3 centimeter one. But mostly they are pedunculated, means they have stalk. So it is usually on the outer side, it is ulcerated and undergo necrosis. Most common glands with the polyps are hyperplastic or atrophic gland. It depends which phase of secretion is going on. Now, hyperplastic polyps develops associated with endometrial hyperplasia important because this is related to the endometrial hyperplasia. Now the chance of endocarcinoma arise, somebody was asking, here is a chance, right? In hyperplasia or hyperplastic endometrium, there is a chance that they may convert into endocarcinoma. So there is another drug which is called tamoxifen, which you give to the patient of breast cancer. They have anti-estrogenic activity for the breast, but outside the breast they propagate estrogen stimulation. So they have developed, sometimes they have seen. They have also, this polyp has chromosome 6p21 rearrangement, which is HMGIYG, right? So this gene can cause tumor. Okay. This is how it looks like. So this is endometrium, right? This is a polyp. This is a polyp. And if you see here, these are tortuous looking or dilated endometrial gland. This is hemorrhage. The lining epithelium is tall columnar, right? Sometimes you see ulceration here, a lot of bleeding here, and you can see here, arterioles. So thick arterioles are seen. So if you see thick arterioles, irregular shaped gland, these are rounded, these are cystically dilated, right? Lined by, the whole thing will be lined by, because if there is a polyp, if this is a polyp, definitely it has a lining epithelium, right? So tall columnar epithelium, somewhere it is ulcerated and you can see hemorrhage at that place. Yeah. I remember it's very important that you have to be very vigilant by looking at these things. There was a patient in which almost she was on an operation theatre because she had a bleeding problem, and some of the radiologists given their report that it looks as neoplastic only. So she was taken to the operation theatre, but the gynecologist was a little curious. And as you know, I know that lady, so she called me. I was a pathologist there. She said, Dr. Brar, I don't want to touch this patient. She's already 75 years of age. And I don't want to do unnecessary surgery. So if you want, I just wanted to be clear. Can I take the biopsy first? And then I said, okay, we can postpone the, surgery. So she took the material out, DMC, and she has sent to me, and it was just a polyp, a huge polyp, which was actually occupying the whole uterus, and it was looking like a tumor. It was just a polyp. And after that DNC clearing, that lady remained, she is not here no more with us. After this one, she was alive up till more 15 years. So she doesn't need that surgery. So it's very, very important that you should have your clinical observation before doing a major surgery. So this was all about the today's topic. Any question? Any question? Ask me now. Yes. It is better because in endometriosis, which part? There are different areas, and I showed you endometriosis of the intestine, because I was looking at the colon biopsy, this one, and I saw this endometriosis there, and I called the gynecologist that she is having endometriosis of the large intestine. So it's better to have biopsy of each and every piece which has been taken out from the body, each and every, which sometimes surgeons become reluctant and they throw away. For example, chronic cholecystitis. It's a chronic cholecystitis. No, it's not that. No. Send that chronic cholecystitis to the pathologist. Sometimes you see some neoplastic or cancer developing in that. Appendix. Appendix. No. Because carcinoid syndrome, carcinoid tumors arise from appendix. So this is important. Don't take this thing easy. Clear? Thank you very much. Yes, what is your question? Anybody? Yes. Right? Okay, so my lecture is over. Please, Dr. Mohammed, come in.